Good morning, everybody. Welcome to Georgia Heart Grand Rounds this morning. Thank you all for joining us today. This program is brought to you by Georgia Heart Institute and the generosity of grants from our industry partners. The planners and speaker have disclosed no relevant financial relationships with commercial interests. I'm pleased to share that today's event has been awarded credit for physicians, nurses, and radiology techs. Your feedback is very important to us. Please take our online survey. The link to that is already in the chat in the Zoom. For those of you that are present in the auditorium, the link to the survey will be handed to you at the end of the program. If you have a question for our speaker, please hold until the end of the presentation. And now Dr. Lal will introduce our guest, Dr. Larry Sperling. Thank you.
Good morning, everyone. Thank you for being here. It's really an honor and a privilege to introduce Dr. Sperling. He is the founder and director of the Heart Disease Prevention Center at Emory. He's currently the Katz Professor in Preventative Cardiology at the Emory University School of Medicine and Professor of Global Health in the Laurence School of Public Health. In addition to his academic appointments, he is the Executive Director of the Million Hearts Division for Heart Disease and Stroke Prevention at CDC and CMS. And he has served in leadership roles and has been the president of the American Society for Preventative Cardiology. In addition to that, he has authored many articles, abstracts, chapters, and has currently been selected to be the chair of the World Heart Federation. Without further delay, Dr. Larry Sperling.
All right, there we go. So Dr. Lal, thanks for the kind introduction and great to spend some time with you and colleagues last evening. Really excited about the commitment that you all have to not only developing a preventive cardiology program here, which already is in existence, but making that a really important part of care for all your patients. I've been trying to get up here now for several years and finally made it, and just great to be among friends and colleagues. I'll be talking about an initiative that I've been working on as part of a team with the American Heart Association for the past year. And this is really one of the first forums where I'm introducing this, so I hope this will be of high value. I'll be speaking about CKMH, so by the end of my presentation, you will know what CKMH means, to prevent CVD. So lots of initials, an acronym, you will be completely on top of it. I have no conflicts related to my presentation this morning. Importantly, my comments today reflect my specific comments and not those of the organizations I work for, work with, or serve. And that photo there is my most important role, and that's being a husband and a father. I'm very proud of our wonderful family. So this is an outline of what I'll be speaking about this morning. First, an overview, and the overview will take you through risk assessment and bring you into cardiometabolic diseases. We'll talk about CKMH, cardiovascular, kidney, metabolic health. And then as I wind down, I'd like to introduce you to the new Prevent Risk Calculator and why this calculator is of high value for you to start using now. We're even going to go through a little practice run. So here's the overview. So in 1961, before I was born, with just 2 words, Dr. William Cannell helped to change our understanding of the underlying causes of heart disease and stroke. And with these 2 words, the entire field of preventive cardiology was born. Now I know it's early. Some of you are still eating breakfast. Does anybody know what these 2 words were? No? Risk factors, right? So this was the Framingham Heart Study. And the Framingham Heart Study was the first on a population level to associate various risk factors that we know well today: age, gender, high blood pressure, high cholesterol, smoking, diabetes, etc., to risk for heart disease. And through this study, we learned that in both men and women, risk factors, when you added them up, had exponential effect on the risk for heart disease. Well, I hope many, if not all of you, have gotten comfortable with using a risk equation, readily available, easy to use. There's an app, you can bookmark it. Why would we even think about using a risk score? Several reasons. Just being efficient to identify those at high risk, which is our goal in primary prevention. Also in secondary prevention, by the way. There's a bell curve distribution of risk in all the patients we see and help with their care. We know from the Bethesda conference back in 1996, we want to match the intensity of our treatment approaches to the risk of a patient, and that holds true today. Unfortunately, clinicians don't do very well guessing. We throw darts, and our guesstimates, are really very imprecise. And then lastly, when we use a risk score, it should lead to better utilization and implementation of guideline-directed medical therapies. This is a slide from the 2013 prevention guidelines, and we know that preventive cardiology begins but doesn't end with the assessment of cardiovascular risk. And today, I'm going to get a hands out there. How many of you at least are familiar with the ACC-AHA risk estimator? We call it through the pooled cohort equation. A few hands. It's been out there for a decade, so would encourage you, because we're moving past it. That's going to be one of my messages today. This risk estimator allows you to simply plug in information related to your patient, and you can get an estimate of their 10-year ASCVD risk. But for younger patients, you can also get an estimate of their lifetime risk. And I find that a really useful construct in terms of conversations with younger patients. If you tell somebody you have a 5.3% 10-year risk of having a heart attack, stroke, or cardiovascular event, that doesn't sound that concerning. But now extend that conversation that if you continue on your current path, you have a 50% chance, flip of a coin, of having a heart problem. That'll get somebody's attention. Well, we base a lot of the calculations on what's called a receiver operating curve, C statistic, and this here is the line of chance. That's flipping a coin. Risk equations have been developed that improve this. So this is called an ROC curve, or a C statistic, plotting 1 minus specificity versus sensitivity. And ideally, what we'd like to do is move this curve up and outward to the left upper corner, because that's a better predictive model. Well, when we estimate risk for our individual patients, it's based upon group averages. It's based upon population data. So even in a perfect world, this is an imperfect process. And I will emphasize several times that risk estimation is a starting point. It is not the end. Well, when we risk estimate, ideally we have a population risk estimation, which is well calibrated to the population in which we're asking this question. But realistically, in some people or populations, we overestimate risk, and in others, especially younger people, women, those with what we call risk-enhancing factors, inflammatory diseases, etc., we often underestimate risk. This is what I call the pyramid of cardiovascular risk assessment. We should start with a risk equation. Family history is not part of the pooled cohort equation, so we want to delve into family history, identify those with metabolic risk or metabolic syndrome, selectively and through an evidence base apply potentially biomarkers or even various imaging studies which may help reclassify risk. I served on the writing committee of the 2018 cholesterol guidelines, and one of the concepts we connected to this in a companion paper as part of the guidelines was the concept of risk-enhancing factors. And so once you calculate risk, you also want to identify risk-enhancing factors in your patients, a family history, primary hypercholesterolemia, those with metabolic risk, CKD, so we'll be talking a lot about metabolic risk CKD today, inflammatory diseases, pregnancy-related conditions like preeclampsia, gestational diabetes, and then high-risk ethnicities. And there are several, but we called out South Asian ancestry. Not to say you should be measuring these in all of your patients, but if you do think about measuring these and your patient has an elevated CRP, we talked about this at dinner last night, an Lp(a), ApoB, or an abnormal ABI, these are all considered risk-enhancing factors. Well, this photo I grabbed many, many years ago from one of our Emory fellows, and she was telling me about our cat, and she showed me a picture of our cat, and I said, oh, I definitely need that photo. So metabolic syndrome or metabolic risk is really common. If we look at populations, let's just say Georgia, US, or globally, anywhere from 1/3 to 2/3 of populations have some degree of metabolic risk. This syndrome is frequently silent. And by definition, you have to have 3 out of 5 criteria: central obesity, moderately elevated triglycerides, low HDL cholesterol, often, what we used to call at least pre-hypertension, now we call it stage 1, and measures that provide evidence of insulin resistance, impaired fasting glucose. 3 out of 5 of these criteria, you meet the definition of metabolic syndrome. When I'm seeing patients in the office or in the hospital, I just did teaching rounds this weekend. I was on call, and a patient was presented with an early event, and they presented me the data. I said, what syndrome does this patient have? And the house staff got it, but frequently we don't call this syndrome out. And I feel like it's really instructive to do that because it connects very much to our discussion today, but most importantly, it connects to the care of our patients. And I'm a preventive cardiologist, so of course, every conversation in some way with my patients is focused on heart disease prevention, but I'm frequently having a conversation about diabetes prevention. 10 years ago now, time flies, we held the very first cardiometabolic think tank in the US at the Heart House, the ACC Heart House. I co-chaired it. We had about 20 organizations represented, and we published this paper in JACC. It was called the Cardiometabolic Health Alliance, working towards a new care model, and we described stages of cardiometabolic risk. Stage A, you're at risk, and that might be genetic risk or environmental risk or community risk or various components of that. Stage B, you're beginning to develop the syndrome, but you don't have it by definition. C, you have it by definition, but no signs of end organ damage. D, you have this syndrome with signs of end organ damage, and both on an individual level, but also a systems level or population level. This helps guide treatment approaches. In this paper, we also commented that healthcare will transition to a greater degree from the clinic to the community, improving access to care, broadening of stakeholders, including public health, community, and industry sectors. Little did we know, a pandemic was about to occur around the corner, which has certainly set us back here. But all of you need to recognize, and we talked about this last evening as well, that in even the best health systems, we only impact about 20% of health and 20% of disease states. So where health and disease occurs is out there, not surprisingly. That's where people live. In this paper, we also described subtypes of the metabolic syndrome. Why do some of our patients have a predominantly vascular manifestation or adiposity manifestation, lipid dominant, insulin resistant dominant. So for adiposity dominant, we called out sleep apnea, which is now called metabolic associated steato. Disease. It's MAFLD, or MASLD is what it is now. I should know that. We published this paper in JACC a couple of years ago, and the paper was about the intersection of what we called at the time NAFLD and cardiovascular disease. And fatty liver is frequently silent. There are no, definitive ways of approaching this from a clinical standpoint. Frequently, we make the diagnosis through imaging, but we should have our antenna up about fatty liver disease and those with metabolic risk, diabetes, especially with cardiovascular disease. And we know now in the US that the number one need for liver transplantation is now fatty liver disease, and it's now referred to it as NAS. MAF, metabolic associated steato-related liver disease. We'll call it that, but basically fatty liver disease. The pathophysiology of this is complex and mirrors underlying atherosclerosis, endothelial dysfunction, insulin resistance, oxidative stress, and lipid abnormalities. So we're learning more and more about the intersection between liver disease and heart disease. Right now, there are no FDA-approved treatments specific to fatty liver disease. And as we move into cardiovascular kidney metabolic syndrome, of course, we can talk about the syndrome, the components of it, but importantly, we need to address this through what I call patient-partnered care. We frequently talk about patient-centered care, but with our patients, it's important to develop a trusted and safe partnership. I still work with the World Heart Federation and chaired what's called the Roadmap on Cardiovascular Disease Prevention among people living with diabetes. We had members of this writing committee from 5 different continents. We presented it at the ESC Congress in Paris in 2019. And when we think about pathways of care, because many of us are clinicians, but either from a health system or the state of Georgia or the US or another country, we need to think about the elements of care as we address prevention, screening, treatment, monitoring, and follow-up. It's important we also understand barriers, accessibility, acceptability from a cultural and social standpoint, affordability, and frequently availability. This is a slide I've showed really all over the world. This is the city in which we live. And although we can determine many genetic variants and really our genetic code for an individual we can assess, our zip code where we live is a more potent predictor of disease or lack of health than our genetic code. And this varies at a very local level. So if we look at, I want to go back one. If we look at Buckhead up here versus Bankhead southwest, about a 6 or 7 mile drive geographically, there's a 13-year difference in life expectancy. So this is the city in which we live, but major cities around the US have similar patterns. There's a paper we published in Circulation, and it points out that, as cardiovascular specialists, we're frequently thinking about those traditional heart risk factors, as I mentioned, like in Framingham, and hopefully we know how to begin to address those, but it's really important that we understand social determinants or social drivers. So poor access to care, healthy food, psychosocial, behavioral, and environmental factors, because the interventions here are very different. All of us, will be asked and required, connected to healthcare dollars, to ask our patients about social determinants of health and document these in the electronic medical record. So this is going live. And in this paper, we published in JACC what we call the health disease continuum. Cardiologists are frequently encountering our patients out here, right? Late disease, acute events. It's really important that we learn more and focus more as opposed to addressing late disease on health promotion and disease prevention. Heart disease, many forms of heart disease really have their onset early in life, so we must take a life course approach to understanding. Really, the optimal window for cardiovascular disease prevention is ages 3 to 5. And I say that primordial prevention, which is what we should be doing on a societal basis, should begin before the moment of birth. And before we move into the CKMH part of the presentation, this was described by Victor Zhao, 35 years ago, the ticking clock hypothesis. So the genes for cardiometabolic risk and cardiovascular risk are very prevalent. And through gene environment behavioral interactions, if that switch flips on, the clock starts ticking. So think about an 8-year-old child, because obesity in children in our country, especially in Georgia, has become more common. When that switch flips on at age 8, the clock starts ticking. And this is one of the reasons that in 2/3 of the counties of the US, we are seeing earlier heart disease, heart attacks, and strokes. And then in this paper, this was a scientific statement for the AHA that I was involved with, just talking about the importance of comprehensive care in those living with diabetes, both without and with heart disease, and the importance of not only comprehensive care as we talk about, lipid management and glycemic management, and blood pressure and all the things we do, but bringing into the fold, asking and addressing the social determinants of health. We've had a challenging past 4 years now, and the COVID-19 pandemic really played out through a convergence of what are called syndemics. First, the lack of population health and a burden of disease. Secondly, the effects of health disparities. And the tipping point was an acute viral illness. And as the COVID-19 pandemic played out both acutely and now long-term, even related to long COVID, we are seeing these intersections continue even today. So that was a little bit of groundwork or overview. What I'd like to do now is introduce you to the AHA's CKMH initiative, Cardiovascular Kidney Metabolic Health. So why CKMH? Well, we know there's an interplay between these metabolic risk factors. They're not individual or siloed. And this interplay, as if we go back to Framingham, magnifies risk with potential for multi-organ dysfunction and also the potential consequences for premature mortality. We have significant opportunities because this syndrome is very common. In fact, the majority of adult Americans are somewhere, if we talk about stages of cardiometabolic risk, are already out of the stage 0. They're already moving through the process. So by definition, CKM syndrome is a health disorder related to the connections between heart disease, kidney disease, diabetes, obesity, and beyond, leading to poor health outcomes. And we have many gaps still to learn about the mechanisms, understand the heterogeneity, meaning why does one patient have these couple of manifestations and another patient have others. We also need to learn that there are competing and integrated risks among these populations. And I think as cardiovascular specialists, we're learning more about the bidirectional relationship between cardiovascular and kidney concerns, but we need to get into the implementation business. I frequently describe our healthcare delivery as fragmented, episodic, and catastrophic. And so we have a fragmented healthcare delivery. a very siloed healthcare delivery, and we have a significant deficiency in primary care clinicians. The expectations are that this will worsen in the decade or decades ahead, and even specialty care in an integrated system, even though we have a common EMR, is frequently disconnected. Pathophysiologically, this syndrome begins with excess or dysfunctional adipose tissue, which is a very active organ system. And this dysfunctional adipose tissue is visceral. Frequently, somebody might not look, overweight or obese, or even by BMI measure that. However, that fat envelops the heart and the blood vessels and embeds itself in the liver, etc., and starts changing the signaling pattern, where we have oxidative stress and inflammation, insulin resistance, and early vascular dysfunction connected to the risk factors, leading to all kinds of changes at a cardiovascular level and systemic level. So not only does this promote atherosclerosis, but cardiovascular remodeling and fibrosis, and often dysfunction. And vascular disease is not disease that is isolated to one vascular bed. When we begin to develop vascular disease, it affects our bodies from head to toe. So an important message with your patients that they'll frequently listen to is heart health is brain health. So as we address cardiovascular disease prevention, we think we're improving cognition across the life course and reducing the likelihood of dementia. So we know CKM syndrome results in excess morbidity and mortality beyond the sum of its parts, can cause end organ damage, and this end organ damage occurs over time. That's the ticking clock. And the mechanisms are pretty uniform in terms of how this process is affecting our bodies from head to toe. We know scientifically this is an amplifier of cardiovascular risk. Frequently, cardiologists, don't pay attention to kidney-related concerns like microalbuminuria, a urine albumin creatinine ratio, even just GFR, unless their patient is in the cath lab and gets a lot of contrast and they're worried about contrast nephropathy. But we need to be stewards of this and realize that this is not only a marker of risk, but an opportunity for prevention and care. Subclinical atherosclerosis is important to think about in terms of a marker that will reclassify risk. And we talked about the underlying inflammatory changes in this disease state. I hope you've heard of Life's Essential 8. The AHA in the past 2 years now has moved from Life's Simple 7 to Life's Essential 8. These are 8 factors that define cardiovascular health as opposed to cardiovascular disease, 4 behavioral factors, 4 health-related factors. And going from Life's Simple 7 to Life's Essential 8, the factor that was added was sleep. The other factors you're likely very familiar with: healthy dietary pattern, physical activity, tobacco cessation, and then ideal weight, cholesterol, blood pressure, and blood glucose. Well, similar to the paper we wrote a decade ago in the CKMH initiative, the AHA has described stages of risk. 0, you're healthy. Unfortunately, and you, by the way, you can go on right now, AHA Life's Essential 8, and you can calculate your Life's Essential 8 score. And I would encourage you to do that for yourself. Unfortunately, most Americans are not here as adults. They're moving through these stages of excess and dysfunctional adipose tissue, metabolic risk factors, early CKD, subclinical disease, and overt disease. As I mentioned earlier, we can't think of each and every person as a clinical-only entity, this socio-ecological framework is really important because many factors affect all of us. Our environments, our internal environment, our proximal environment, our community environment, our family environment, and beyond. The air we breathe is actually the air quality index is a marker of cardiovascular risk, not just respiratory risk. And we know that particle pollution and extreme heat, both acutely and chronically, can greatly affect cardiovascular risk. Well, as you're being asked to gather tools and data related to these social drivers of health, they can be embedded in your EMR with reminders to ask and add this data. There are tools that we have listed in the documents we published through the AHA. We published 4 papers in circulation, a presidential advisory, 2 scientific statements, and a methods paper related to the Prevent Risk Calculator. Well, we all live in somewhat different worlds. Some of us are in the fee-for-service volume-based care. In our country, there are some in ACOs or value-based care systems. In both of these healthcare delivery approaches, we have opportunities for interdisciplinary care. And more we realize that the traditional model of medicine, one doctor, one patient, doesn't work anymore. So medicine and the best care of our patients is very much a team sport. And that team should be functioning as individuals, but as a team in the highest capacity. I'm not going to go into detail, but if you want to reach into our documents, there are many figures and algorithms about how to go about addressing these risk factors as you stage your patients, identify their CKMH risk. And this approach is very much guideline-based and guideline-directed, synthesized by the current guidelines and the guidelines in progress. We come back to that patient-partnered care. I still see patients. I have clinic at Emory today, so I'll be trying to get back to Atlanta after Grand Rounds. I always tell my patients that we sign a contract to age 100, but we renew 1 year at a time. And I say this is a team effort, you and me. And I also say you always get more votes than me because you're the patient. I want to understand your preferences, your questions, your concerns, as together we focus on your care. And this is truly a call to action. It's, a call to action we not only need now, but we needed 10 years ago, 20 years ago, because in our country, the predictions are by 2030 that 1 out of every 2 Americans by definition will be obese, and 1 out of every 4 will be severely obese. And although central adiposity is part of this syndrome, it is not the totality of the syndrome. So, recognizing this risk is critically important to addressing this risk on many different levels. So, gave you an overview. Now you know what CKMH stands for. Now we're going to move into the new Prevent Risk Calculator. We come back to where I started, related to risk factors and risk assessment. And now you're familiar with the CKM syndrome. We know there are preventive strategies to address this, lifestyle and behavioral, often medications. And as we approach care in our patients, that care should be based on that risk assessment as a starting point, but not an end. We know absolute risk is when we do a risk estimator. That's what we're really calculating. There's also a concept called relative risk. So you can be that 8-year-old child and your absolute risk of having a heart attack or stroke when you're 8, unless you have homozygous familial hypercholesterolemia, probably approaches 0. But if that 8-year-old child, their relative risk is 10 times above the rest of the 8-year-old kids. That's time to begin addressing risk in that child. Importantly, risk assessment's a starting point, but it should lead to implementation and guideline-based care. So the PREVENT risk calculator, PREVENT stands for predicting risk of CVD events. An incredible methodology was used by colleagues around the country to derive and validate this risk calculator. And then I'll mention today what are the implications of using this risk calculator estimator. But learning about it today, and once you walk out of the room, won't do anything. So we're going to go through a little test drive because it's going to be about implementation. This was a paper in JAMA that reviewed the take-homes about our PREVENT risk calculator. What should you know? And what you should know is this risk calculator enables risk estimation for 10 and 30-year risk of not only ASCVD, which was the pooled cohort equation, but now you can estimate risk for total CVD and heart failure. It incorporates kidney and metabolic diseases. For the first time, this risk estimator eliminates race and ethnicity, but it factors in social determinants of health using a surrogate for the social deprivation index based on your zip code. This social deprivation index incorporates our income, education, employment, housing, household characteristics, and transportation. And the methodology in which this was derived and validated is based on over 6 million individuals from 46 data sets, including both population health, but also real-world health system data. The goal is not for you just to learn about it today, but to embed this into your EMR. It should be easy to use, and the complete model, our goal was to make it available online by February 2024, and we met that. So the methods, oops, I'll go back one. Yeah, so we'll just come back to 46 data sets, over 6 million patients, a derivation model, a validation model, and utilizing those traditional risk factors from Framingham, but moving beyond that with BMI. BMI is very imperfect, but works okay in a population. Adding on measures like urine albumin creatinine ratio, A1C, that social deprivation index, and then the outcomes going beyond the previous risk calculator. Now, we know from the methodology that the ability for this calculator to discriminate is significantly better than the previous pooled cohort equation, and the ability for it to calibrate is at least on par or superior to the prior risk estimator. So what are the implications of this PREVENT risk calculator? One is starting risk assessment earlier in life, right? That life course, the ticking clock hypothesis, that risk doesn't begin at middle age or just when we start detecting overt events. And we must be aware of this and think about risk across the life spectrum. Comes back to that Bethesda conference where we want to mirror our preventive strategies and the aggressiveness and intensiveness of this to the absolute risk of our patients. So ideally, when we find somebody at higher risk, we can not only lower their risk, but change the trajectory of their risk across the rest of their life. So future directions, developing the online calculator, which has occurred, patient-centered or partnered care, connecting this risk assessment to evidence-based approaches, and delivery of care with a lens of health equity. This is, the photos of our team members. We met weekly for, 6 months to a year working on this initiative, and there are 4 papers, as I mentioned, that are published online. But here comes the test drive for all of you. So I'm assuming everybody has an iPhone. So take your iPhone out, look up Prevent Risk Calculator, and it should come up easily. Anybody having problems with it coming up? So now, you can put in an imaginary patient if you want. You can plug in yourself, age, total cholesterol, HDL, systolic blood pressure, BMI. If you did have data on estimated GFR, which we frequently do because the lab does that for us, we can put that in. Diabetes, yes, no. Smoking, yes, no. Antihypertensive medications or lipid-lowering medications, yes, no. And then, if you do have the data for urine albumin-creatinine ratio, and this hopefully will get us all thinking about that connection between the kidney and the heart, and A1C and zip code. And then you just press calculate, and you'll be able to look at the 10 and 30-year risk for ASCVD, total CVD, and heart failure. So I'm not sure if there's an app yet. We tried to play with this on rounds this past weekend, but you can just bookmark it, and you can bookmark it on your iPhone where it'll kind of come up as it's right there on your iPhone, or if you have a laptop or an office computer, it can be bookmarked there. So some of the main points I hope that you distilled from my presentation today are that CKMH is important. It's important to focus on health versus disease, but that CKM syndrome is common. And this syndrome develops across the life course. And the impacts of this syndrome are significant. Risk assessment, we're moving beyond where we were 10 years ago. That's a good thing. Risk assessment's a starting point. It is not perfect, but it's not an endpoint. You can still apply the risk-enhancing factors. Absolutely, you should have what we call a clinician-patient risk discussion. That's where we begin to get to know our patients and have a trusted dialogue over time about their health. And now all of you have done a test drive for the Prevent Risk Calculator, which is great, so you're all aware of that. So as I begin to conclude, we talked last night, you're all familiar with Ebenezer Baptist Church. It was the home church of Dr. Martin Luther King, who said in 1966, of all the forms of inequality, injustice in health is the most shocking and inhumane, and this exists very much today. All of you probably know who this was, number 42 of the Brooklyn Dodgers, Jackie Robinson, and the slide, the figure here or the photo on the left is him stealing home plate during the World Series, a very famous moment in sports history. What you may not know is that Jackie Robinson was born in Georgia. We talked last night about South Georgia, and I'm from New York, but my wife is from a small town in Southwest Georgia. So Jackie Robinson was born in, hopefully I'll pronounce it correctly, Cairo, Georgia. And then he and his family moved out to the West Coast. This is a plaque of the birthplace of Jackie Robinson, and the plaque is riddled with buckshot, defaced. What you also might not know about Jackie Robinson is that Jackie Robinson was an example of CKM syndrome. While he was actively playing for the Dodgers, he was developing diabetes and the consequences of diabetes that affected his eyesight. And although he had access to care, many of his risk factors unfolded and were largely untreated. And he developed type 2 diabetes, obesity, cardiometabolic risk, And unfortunately, in 1972, at age 53, he died of a sudden cardiac event. It was mentioned that I serve as the executive director of the Million Hearts Initiative for our nation. It's a CDC CMS initiative. It's been in place for over a decade. We are supported by appropriations from Congress. We work across all 50 states. Million Hearts is an example of what I call possibilism, that we have the knowledge, tools, and resources to prevent over 1 million heart attacks, strokes, and cardiovascular events in our nation through building healthy communities, optimizing care, and a focus on health equity, a core focus on health equity. Million Hearts does its work through its partners, several hundred partners, federal and private. And the building healthy communities, I alluded to some of this in my presentation, decreasing tobacco use, decreasing physical inactivity, decreasing particle pollution exposure. The optimizing care we call the ABCs, appropriate aspirin and anticoagulation use, improving blood pressure control, cholesterol management, smoking cessation, increasing utilization of cardiac rehab, and the core focus on health equity. We've identified 5 specific populations and definitive actions to address health inequities across our nation. People who live in rural areas or other access deserts, people with lower incomes, people with behavioral health issues who have a greater chance of tobacco use, people from racial and ethnic minority groups. And, very relevant in Georgia is pregnant and postpartum women with hypertension, because in Georgia we have the highest maternal mortality rates in the country. We have many recognition programs, hypertension control champions, but I've had several conversations with Dr. Habib Samadi from your institute here that it would be great to see you be the first institution, hospital or health system in the state of Georgia to be a Million Hearts hospital or health system. And if there's interest, our team can help coach you to get there. This is just recognizing that Johns Hopkins this past year was recognized as a Million Hearts hospital and health system. Well, I know you have your big conference in June. I'm going to make it in person this year. The last 2 years I've been virtual, but I'll hope to be there for at least one night and a presentation. But at Emory, we have one of the longest running preventive cardiology meetings in the country. It's called our Escape meeting. So just in case you want to spend a few days in Amelia Island, Florida, May 29th to June 2nd, and learn a lot about heart disease prevention, see if you can make it. So wonderful to meet with all of you today. Really appreciate your time and attention. Glad to address questions or comments. And now it's not about learning, but it's about applying. And that's the real example of what's called true learning. Not just listening, but applying what you learned today when you walk out of the door for Grand Rounds. So I thank you again.
Does anybody have any questions for Dr. Sperling? I know we have one online. Is there anybody here in person? If you have a question, please raise your hand. I'll come up to you. Okay. Dr. Lal, do you have anything to share while I head up there to read the question?
Well, I certainly learned a lot today about CKMH, but I also learned a little bit about baseball. So thank you for that very insightful talk. Could you speak a little bit more about the intersection of CKMH and your Million Hearts program and how they combine together in probably not only just a local US-based, but even an international initiative in really improving cardiovascular disease outcomes?
Yeah, so first I'll just qualify that Million Hearts is an initiative based and focused only in our country. I still, in my Emory world and the rest of my worlds, am involved with global health and the World Health Organization, World Heart Federation. This is a priority, by the way, of WHF, and we're holding a forum right before the World Heart Summit in Geneva, Switzerland in May that will be addressing this concept we call it multi-morbidity chronic conditions, and how we should begin to think about these as not, separate entities, but integrated entities, and address these through integrated care approaches, not just in the clinic or hospital, but in its totality. Related to Million Hearts, if you look at the Building Healthy Communities, Optimizing Care, and a focus on health equity, although we don't have flashing lights saying CKM syndrome, really you can apply what you learned today to implementation of the Million Hearts Initiative. And the Million Hearts Initiative, preventing 1 million heart attacks, strokes, and cardiovascular events, doesn't happen by the initiative. It happens related to all of you and the work you do each and every day. So I think it is very relevant. The CDC has divisions for diabetes translation, a division for, it's called nutrition, physical activity, and obesity. So, the CDC itself is, focused on addressing this type of concern on many different levels.
Thank you. We do have a question online. As you mentioned, sleep is being recognized as an important risk factor for heart disease. Can you please talk about the evidence for this and perhaps about potential mechanisms for this relationship? And is there a risk equation that incorporates sleep yet?
Yeah, sleep is built into, if you go to Life's Essential 8, it will ask you about sleep, and it will be built into your Life's Essential 8 score. Talk about sleep. All of you had to get up pretty early today to make it for Grand Rounds, so I thank you for that, because I have some people in the audience to speak to. That's great. But sleep and sleep disorders can affect our biologic clock. So the impact of, and by the way, so many people have challenges with sleep. Occult sleep apnea, I diagnose this in every other patient. That really affects their cardiovascular health and cardiovascular risk. So let's just use sleep apnea, but even just sleep disorder, or people who are shift workers. They work in the evening and then they sleep during the day. Through that central mechanism of cardiometabolic risk, so inflammation, oxidative stress, stress hormones go up, cortisol levels, norepinephrine, epinephrine, and so our body is never able to get into a true healthy homeostasis. And whoever asked that question, there's a lot written about this, and if you want to dig into it deeper, there are papers outlining that at AHA, but even beyond as well. But it's something we often don't ask our patients about. So many times our patients come in and one of their main complaints is, I'm fatigued. And of course, as a heart doctor, we say, okay, maybe it's your heart. But fatigue can be related to so many different things. So learn to ask the question, how many hours of sleep do you get at night? And 4 to 5. Okay, well, I think at least in part, I know why you're fatigued. And there's a reverse U-shaped curve. We're in the middle of writing a paper right now related U-shaped curve reversed. So lower risk, there's an optimal. So it's a reverse U-shaped curve. So at the top of that curve, that's optimal sleep. And it might be 7 to 8 hours, let's just say that. On either ends of the curve, too little sleep or too much sleep, that is associated with adverse health.
So final question, and this is from the same person that asked this question before about sleep. From an imaging standpoint, there is abundant data to support the value of coronary calcification and risk prediction. But in my mind, it's too late by the time calcification occurs. So your thoughts about using paravascular adipose tissue as seen on cardiac CT as a risk predictor at an earlier stage?
Yeah, certainly there's the timeline of atherosclerosis. We know this through pathologic studies. calcification of the arteries is often a fairly later part of the pathobiology of atherosclerosis. So yes, agree that once you have calcium in your arteries, it's later in the disease process. It's often not so late that you can't address the disease and impact that life course or trajectory. There are other measures by imaging, and I mentioned the importance of visceral adiposity. So, I mean, vascular adiposity, I mean, isn't that readily seen on a CT? I mean, maybe on MRI a little bit in larger vessels like the aorta, but you can look for pericardial fat. We talked about the importance of MASLD. I need to get that one down. But MASLD is what it's called now, so fatty liver. And so learn to extract as much information as you can from your patients that have been imaged. I wouldn't advocate for doing a CT on everybody at age 30 to see if they have, various signs of visceral adiposity. We can predict using your prevent risk equation and or just start identifying those with metabolic syndrome. That's easy. You have 5 fingers on this hand. Okay, 1, 2, 3. Oh, you have metabolic syndrome. There you go. But we have lots of clues. And when I see a patient in clinic, I look at their whole chart, not just the heart and vascular part. And I'm going to see a patient later today that had a CT of the abdomen and pelvis last year, totally unrelated to their heart. And this is a gentleman who's been a bit hesitant to think about a statin. And part of our conversation will be that he was found to have atherosclerotic calcification of the abdominal aorta. And so that we don't need to do anything else. You've got atherosclerosis. Here we go. Let's try to together do all we can to prevent you from winding up in the hospital with a preventable event. Any other questions or comments? Looks like we're 8 o'clock on the button.
I had one question.
Please.
Could you comment on the role of intermittent fasting in reversing metabolic syndrome?
Great question. I would have said you were prepared. I got you prepared to ask that because I've given several presentations about this. At Escape, that'll be one of the presentations I'll be giving, is about time-restricted eating or feeding. We talked about this at dinner last night as well. We've written a few papers about it. First, there's a difference between true intermittent fasting and time-restricted eating or feeding. True intermittent fasting is where you pick a few days each week and you fast, except for just clear liquids. I've tried it. You cannot sustain this for the rest of your life. The Greek derivation for diet comes from dieta. That means a way of life. It doesn't mean torture. It means, so time-restricted eating or feeding is reducing your eating or feeding window down from, let's just say, average of 14 hours of eating as Americans, because we're eating all day and all night, and then we go to sleep. So we reduce that window to 8 or 10 hours. And the data is very encouraging. Although small studies, a colleague of mine at UCSD, Pam Taub, and her group have done a lot of work on this. It shows promise for addressing metabolic risk. What we don't know for sure is whether there's something magical about changing this circadian biology, but it does affect inflammatory factors, oxidative stress, metabolic factors, but it may just translate to we're eating less and that we're taking in less calories. But even if that's the only benefit, it's sustainable. People can do time-restricted eating once your body gets used to it and rebalances. I mean, you potentially can do that for the rest of your life. So thanks for the question.
Thank you. One quick one just came through. Thank you for an excellent talk. We have Life Essential 8. Do you foresee depression in the future being added as number 9?
Wow. I do think these questions were maybe prepared in advance because they're spot on. I was not part of the group that moved from Life's Simple 7 to Life's Essential 8, but I know that there was a lot of debate. Sleep versus stress, anxiety, depression. So I can't predict if there'll be Life's, I don't know, whatever, nautical 9 or whatever they're going to call it, but clearly stress, anxiety, and depression is a really important factor for risk for all chronic diseases, heart disease, metabolic risk, diabetes. There's a study called InterHeart. Salim Youssef was the first author, and it looked at why people had heart attacks all over the world, and not surprisingly, on every continent, and they didn't look at Antarctica, but every other continent, why people have heart attacks were the same. And one of the really important points from InterHeart is that having stress, anxiety, or depression is as powerful as a risk factor as having diabetes, twofold increased cardiovascular risk. So great question, very relevant. Right now, not part of the official construct, but should be part of what you're asking your patients. In our prevention center, we would have every patient, and in our cardiac rehab programs, everybody did a PSQ-9 screening questionnaire for depression, not because I'm a psychiatrist or want to be a psychiatrist, but it's important to identify that, just like we identify somebody as having high blood pressure.